Good evening, ladies and gentlemen, and welcome to ProMed's webinar this evening on the operational side of cardiac arrests. You can see a couple of people are still entering the waiting room, so we're just going to give them another minute or so to get joining in. And I can see quite a few people have already found the chat and are starting to use it, which is absolutely fantastic. So please carry on introducing yourselves and sharing your social media contact details, LinkedIn, Twitter, Facebook, Instagram, etc. And we'll be sharing ours. So please, if you're not already, please do follow us on all of those platforms. Okay, good evening once again, ladies and gentlemen. And first of all, a very happy new year to everybody. I think this is the first time we've seen our regular webinar participants since the beginning of the year. And what a strange and interesting time it is. So welcome back, everybody, and hello to all of our new faces. Very pleased to see there are 43 people in at the start of this webinar, which is absolutely fantastic. My name is Matt Dinnery. I'm the Managing Director of ProMed. I'm a qualified teacher. Clinically, I'm FREC 4. I'm also MIMS qualified and have a degree in biomedical sciences. Operationally, I've been working in the event sector. I've been leading teams in sort of safety, security, and medical for the past 14 or so years, working quite often in control rooms and on the sort of behind the scenes side of the large events. Fantastic. Can see we've got a lot of people in here from all over the UK and Ireland. I can see some people from the US. I can see we've got everybody from sort of CFRs, FREC 3s, right the way up to specialist paramedics, clinical educators, and we've even got some student healthcare professionals in tonight. So welcome to you all. I hope that the content that we're going to go through tonight is relevant to everybody, and it should be a nice discussion around best practice. So before we get started, we do provide these webinars free of charge. So we do like to take a little bit of advantage and have a little bit of an advertising moment at the beginning, just so you know who we are. So ProMed, first of all, is an event production, film and TV medical provider working all across the UK. We are always on the lookout for high quality staff who, take CPD seriously, such as all of you guys, who have the appropriate qualifications and want to work as part of a team that feels very supported and very well led. So we are a living wage employer, which means effective from the 1st of January, we are now paying £11.80 an hour outside of London or £13.55 an hour inside of London to those who are self-employed casual bank staff. That allows you to contribute to your pension, pay your national insurance, pay your income tax, and still be left with the living wage that you would have if you were employed. We're also a signatory of the prompt payment code. That means that we pay all of our suppliers within 30 days. And according to my accountant, we're actually paying our suppliers within 5 days at the moment. We like to ensure that you guys as workers for us are treated very fairly, and if you're doing a job for us, we think it's only fair that you get paid promptly for doing so. So at the moment, we are looking mostly for first responders, so those who've got FREC 3 or higher, and emergency medical technicians, so those who've got FREC 4 or higher. And we're also looking for people who've got the COVID supervisor qualifications. So if you do join us, we are looking to roll out the free tests that are available for COVID supervisors, provide all the guidance and resources that you need in order to pass those. And that makes you a lot more useful in the film and TV industry, as at the moment there's a huge demand for sort of COVID supervisor trained medics, as you can imagine. So if you are interested in joining us on something of a more formal basis, all you need to do is drop an email to apply@promed999.co.uk, and one of my leadership team will send you our application form back. Once that's been received, the leadership team will review it, and if we're happy, we'll invite you to send us your qualifications, and we'll arrange a Zoom interview with you. We do interview everybody properly. You know, we are a reputable provider, and we do follow all the safer recruitment processes. If you're not sure what they are, we did do a webinar on that last year, and you can watch our webinar on YouTube. Next thing to say is that through our QualSafe Training Centre partner, STC Training Solutions, we are able to arrange for places on a number of QA courses. All the details are available on our website, promed999.co.uk/training. We do offer, for example, the QA Level 3 certificate in First Response Emergency Care, or FREC as that's more commonly known, and STC include the Level 3 award in administering medical gases, so that also explains how to use Entonox. The combined cost for that course is £395, and the next available course on weekdays begins on the 22nd of March, or on weekends would begin on the 13th of February. You'll get a copy of Ambulance Care Essentials when you do that course, so you are left with a nice thick chunky book that you can go away and develop your practice further by reading around the subject. Similarly, for the Level 4 FREC at £495, you get a copy of Ambulance Care Practice. So that's an even thicker book with even more clinical information. And we do encourage everybody to read around their subject. And when you're working for us, we do expect to see our staff who are kind of on standby in first aid posts or whatever, actually reading through, be it journals, be it workbooks, anything like that, to help keep their practice current, up to date, and responsive. If you hold those already and you want to do your immediate life support, next available course, which I'll be on myself, is on the 7th of March. All of these courses are down in Aylesbury, but we are looking at running some courses in South Yorkshire later this year. So if you want to join me to requalify on your immediate life support, come along on the 7th of March. That includes a copy of the Research Council's latest published guidelines, £125 there. And we also are able to get places on the Level 3 award in Safe Administration of Life-Saving Medication courses if you're working for a CQC provider and you've done the appropriate CPD for your FREC 4 already. That's £200 over 2 days. You get a physical JR Calc pocket book to take away and keep in your trousers, so you can always refer to the guidelines that you should be referring to when you're administering drugs. And that course runs on the 27th and 28th of March in Aylesbury. So if you're interested, do visit the website promed999.co.uk/training. Okay, just to make you aware that we do have a code of conduct in place for everybody that attends both our physical and our online training courses. You do have the right to expect a space free from bullying, intimidation and harassment, to be treated with dignity, respect and courtesy and not be discriminated against. Full code of conduct is available on our website, so if you do witness any inappropriate behaviour and need to report anything, privately message one of the two ProMed admin teams on the webinar this evening, or just email webinars@promed999.co.uk afterwards, should you need to. Basically, what we do is we encourage a lot of conversation, a lot of dialogue in the chat. We do get some people involved, open their mics and speak towards the end during the Q&A, and it's absolutely fantastic to have that ongoing dialogue and conversation, as long as everybody's respectful to one another and is, you know, debating rather than arguing. We're more than happy to facilitate that, so we do like to see everybody getting involved. Tonight, we're going to be talking about the operational side of cardiac arrest. So that's everything from pre-arrival, both when you just arrive on shift and you're thinking about what you might do that day, but also when you're notified of the situation and what you're going to do on your way there. We're going to look at what solo responders need to consider, including the use of bystanders. And then we're going to look at more of the team structure, so team leadership and the importance of communication. We're going to look at what non-HCP crews should be focusing on and why, the tasks that HCPs need to be assigned to, and then we're finally going to close by reviewing what should happen in the aftermath of a cardiac arrest for the staff members that were involved. So let's just have a little look. You are an event medic. You're working as part of a team of 6 people, in addition to a medical manager who is present at the event purely in an operational role. You turn up at the first aid post in the morning, and you might know one person who you've worked with loosely once or twice in the past, but you don't know the other 5 or 6 people. So what kind of things would you expect to be going through in the morning before the event becomes operational? Throw your suggestions in the chat, please. Absolutely fantastic suggestions coming through from everybody. So Neil says the skill levels, Zoom user says the intros, Dorota says a proper briefing. Graham has hit the nail on the head there. Absolutely. Where's the kettle? Lisa's saying we should look at roles and responsibilities. Chris is saying skills-based, familiarity with the kit and testing it. Skills and experience from Patrick. Pete says the equipment, skill levels and experience. Patrick, how they take their tea. Yeah, that ties in with what Graham said about the kettle. Dorota, the available supplies, the meds and the defib. Beth, the event capacity. Amy, is the kit ready to use and in date. Chris, setting the designated roles in case cardiac arrest. Colin, the nearest hospitals. Neil, checking the battery and pads on the defib. Gavin, equipment checks that they're all in date. Thomas, confirmation, familiarisation with defib, check the leads and the dates. Graham, the more serious side, job roles, responsibilities, kit familiarity, checking the batteries, the zones, etc. And Elise, coffee, yeah, there are some really strange people who don't drink tea. I don't think we employ any of them, so it's all good. So we are absolutely right. So as part of your standard event briefing, one of the things, you should be getting told the layout of the event, what zones is going to be, who's going to be in what area, what the capacity is, what the start time is, the finish time is, what's close to the first aid post, all of those kind of things, absolutely. We should also know where the event's located in the real world in terms of, what hospitals we've got, what referral options we've got, because not everybody goes to a hospital. We also need to consider that pharmacy, local urgent care or GP services, acute mental health services, social services are all possible referral options, of course. And then it moves on to the people themselves. So who is everybody? We should be looking for an opportunity to introduce ourselves. We should be giving an opportunity for everybody to introduce themselves by name, give a little bit of their skills, a little bit of their background, so that everybody kind of gets a little bit familiar with who's who. And then we should look at the equipment. So we need to look in the first aid post, see what's around, see how it's laid out. If you're using any of the ProMed kit bags, we're absolutely happy for people to take the seals off and have a look through them, because we would expect you, if you were turning up to a casualty, to actually know where things were, so you knew when you opened the bag where to put your equipment. Likewise, if you're bringing your own kit, one of the ProMed leaders would probably ask you to open your kit bag, and we would do a random sample just to check that the equipment you have was in date and where necessary serviced. We use GMM Sales as our service partner, and they do a very high quality job on all of our equipment for us. Others are available, including Clinical Engineering and AALS, of course, very reputable people who we've used in the past as well. So you'd be checking through all of that. Any electronic equipment, generally turn it on. I found out a couple of weeks ago, one of our cardiac monitors, I was on my way to be operational. I checked it the night before. As I turned it on, the screen went all fuzzy. That's never done that before, and it was about 2 weeks after it had been serviced. So I went and swapped it out for one of our other monitors and checked that monitor, and it was working absolutely fine. but you just don't know. Just because something worked yesterday doesn't mean to say it's going to work today. What I like to do, especially when I'm on an event with my electronic kit, if I've got a tympanic, I'll do my own. I'll do one of the staffs. If I've got an IR, I'll do that. If I've got a cardiac monitor, I might well throw the BP cuff on and the SATS probe, because I know that the medics around me should be relatively healthy. So I'm expecting to see a value in the normal parameters. I'm expecting the machine to be able to read that straight away and not kind of dilly-dallying, overpressurize the cuff or anything. It's really important to kind of do those actual hard checks in the morning, because the time to find out that something's going to play up isn't when you first use it on a patient. So really pleased that everybody's kind of gone down that route as well. And absolutely what Chris said, what roles are we going to take in a cardiac arrest? So if you're going to be patrolling in teams of 2, think about, right, well, who's carrying the bag? Who's carrying the radio? I mean, at ProMed, everybody has a radio, so that's not an issue. But I know with other providers, there's usually only one radio between a pair. So who's going to do what? If we're walking around and we come across an unresponsive patient, who is going to assess that patient? Who is going to call it in on the radio? Because that's one less decision you have to take in that moment when your adrenaline kicks in and it's fight, flight, or freeze. Because it doesn't matter how experienced you are, if you're not prepared for it, if you haven't got that decision already stored in your memory, you are still going to have fight, flight, or freeze. It is a natural reaction. It is how our body is trained to deal with a threat or a serious situation. It's what the adrenaline does to our body. So the way we counter that is to have what we call memory items. So if you've looked into how airline pilots are trained, for example, there are certain things on their quick reaction handbook called memory items. And what that means is, in a pressurized situation, they have to be able to recall and carry out those items without consulting the quick reference handbook. So your memory items as a medic responding, or a medic who is patrolling and encounters a casualty who is unresponsive, is going to be check for danger, check for response, check the airway, check the breathing, and communicate with whoever is in control. They need to be memory items. So one person does the first 4, the second person communicates with control. But who's going to do what? Don't wait until the situation happens, because while that situation is happening, you go and look at each other and go, yeah, you go down, I'll radio it in. Right, well, there's 5-10 seconds where that patient is potentially not been getting oxygen, not been getting adequate perfusion to their tissues, and therefore that tissue has just been dying for a further 10 seconds, when it basically didn't need to, because you could have already made that decision. Likewise, the other thing that we do is we look at what roles we would have if it is an arrest. So if there's only one healthcare professional on the team, in the control room, our automatic sort of memory item is, if notified of an unresponsive casualty, dispatch that HCP unless they're dealing with something that is more serious. If we've got multiple HCPs, our control room team would have already discussed and deliberated the protocol for which one is going to be sent, because it might not necessarily be the nearest. It might be that we're always going to send the ED doctor who deals with this, or it might be we've got a cardiologist who just happens to be in really bad luck, and in the last 3 months has had countless arrests and is absolutely shit hot on it. So we think about all these things and we plan them before we get there. So Neil, alerting to cardiac arrest on open channels. So at ProMed, any radios you get should always come with an earpiece, and it is our expectation that all staff will wear an earpiece at all times. But you're absolutely right. There are other providers who don't provide earpieces, and therefore that does make communications less private, especially on shared channels. However, a lot of research into sort of crowd management, crowd safety, and the psychology of panic generally says that actually people don't panic, people don't flock to the scenes of incidents. In fact, unless you're giving them direct instructions, they're most likely to just ignore it and carry on with their own business. So clear, plain English, no code words, no numbers, no letters, plain English, spoken clearly and slowly over the radio is the best way. Planned ambulance service pre-alert system too. Yes, certainly, you know, when we do control rooms, all of our phones are set up and we have one-touch keys to the nearest dispatch desk or the event desk or the control room duty manager. You know, it's literally one touch gets us through to the right person we need in the ambulance control room. Thanks to our investment in technology as well, it's not quite one touch. We now have to press a BLF button on our mobile telephone screen, followed by that. So it's basically 2 or 3 touch on a mobile phone. But again, it gets us through to the right person. And it's the same layout as our desk phones. So when we're doing stuff, our operational stuff is well planned in advance, and absolutely that kind of, you know, we know what we need to say, we know who to say it to. Absolutely. In the event planning phase, before we get anywhere near the event, we would have already decided which entries and exits can take vehicles, which entries and exits should take vehicles, what the blue route's going to be, under what circumstances we would not use the blue route, you know, perhaps depending on where a patient is and if it's easier to get an external vehicle straight to the patient, or do we move them to the first aid post. All of those scenarios will have been through a tabletop exercise procedure, and we would have those planned and rehearsed, and certainly the control room would have the event operations plan open on a screen with a search function readily available. Sometimes we do the hard copy as well in case of technology failure, or some people just like to open a nice spiral bound copy. That's absolutely fine. I'm personally a searchy person. I just type in what I need and I'll bring up the relevant screen. I've already got my map permanently on display, so I can see where there's my casualty, what gates have I got, what route am I going to use. And again, all that information will have been communicated well in advance to the local NHS ambulance service, so that should they need to be called in addition to what resources we've already got there, then again, that's part of a pre-planned and pre-agreed procedure. So yes, how do we get from locations to treatment centres? Do we use a conventional ambulance? Do we use a buggy like Polaris, or just a normal kind of John Deere? Do we use just a stretcher on wheels? Do we use a stretcher where we have 4 people carrying it? All those kind of different permutations are all planned out in advance. And again, control have already got those pre-planned procedures in the management plan that's ready to go. So while everybody's dealing with the cardiac arrest, the controller should be opening that document and reading through, right, what are we going to do for needing to move a patient on a stretcher in this area? Okay, I now need to start getting these people ready, and I need these people from the rest of the control room to start helping me. So all of this is before we've even got to the site. You know, nobody's actually arrested yet. This is before we've got there. We have planned everything for the event before we've simply got there. So absolutely the start shift briefing. So now consider the other scenario. You are bimbling away, just having a look, and you've noticed that really nice churros stall, you know, a nice bit of cinnamon, and they've got a nice bit of cream or chocolate sauce, whatever your preference is, and you're kind of walking over there thinking, I'm going to make friends with these guys, very nice, completely relaxed. And all of a sudden, you know, your radio goes off. Response 1 from control, red call, unresponsive patient, zone 1, grid reference alpha 3. Please respond, over. What's going to go through your head? What else do you want to know at this point? What do you want to quickly put your hands on as you're starting to walk in that direction, just to be 100% certain that you've got it? So throw your answers in the chat. What other information do you want to know? And what are you just going to put your hands on and check where it is? So Patrick saying AED, Vishwana closest to the team, Elise who's where, who has what, Patrick gloves and mask, Elise PPE, Patrick BVM, Chris gloves BLS kit, Nathan PPE and shears, Elise what do we know about the patient, that'll be David saying a Tyvek suit, Patrick who and what else is coming, Chris where's my panic button, Neil tough guts and gloves, Pete what's the casualty status, and Elise how long ago they collapsed. So absolutely, my ears at this point would prick up. Certainly when I'm on the ground, I've been on the ground plenty, my ears would now really sharply listen to the radio. As soon as I've acknowledged I'm on my way, right, who else are they sending? Are they sending any vehicles? Right, they're sending them. They're an HCP. Right, yes, I know they've got extra kit. So I'm listening intently. I might well try and jump up and remind them that I don't know anything about my patient yet. What gender is my patient? What age is my patient? Is there ongoing CPR? Was it witnessed? Have we just had collapse? Do we actually know if that collapse is unresponsive? Am I getting a lot of adrenaline surging through my body when actually someone's just, fallen over and not quite gotten up yet? Has anybody pressed the good Sam button? Yes, absolutely. Yes, as I'm walking there, right, yes, then, yeah, I've got the cardiac monitor in my hand, or yep, my AED's on my side. Yep, I've definitely still got my bag. Yep, I can feel the oxygen at the bottom. Right, and I'd be thinking, right, memory items. Soon as I get there, you're going to radio, I'm going on the ground. Right. I would probably say to my colleague, while I'm on the ground, open the bag, go into this coloured pouch and get the bag valve mask, because that's something I'm going to want. Or I might well say, I'm going to drop the defib. Can you open it and be ready to open the pads? So we're going to agree our first actions. So if it's confirmed that it is an arrest, because we've no longer got this fight, flight, freeze scenario going on, we know we're going into something that could well be an arrest. So we're now going to agree. You're calling it in, what we find. I'm going to check and confirm it is. You're going to get this out. I'm going to start CPR. So by the time you arrive, there are absolutely no decisions left to take. All you need to do is your memory items. All you need to do is stick to the clinical. The who's doing what, why, where, when is already being decided. So absolutely, how am I going to get through the crowd when we approach any ongoing dynamic risk assessment? Take control of the crowd, get space and dignity. There's two of you. That ain't happening. If I've not yet heard control pipe up and say security have been dispatched, I might well try and jump on air and just remind them, have I got crowd management? Certainly my ProMed controllers, I wouldn't even question them on that. I would know that they've already got that communication through the control room and have people already there. To be fair, my ProMed controllers will probably have already spoke up on air and said information for security deployed. They communicate outwards very, very well so that you know exactly what you should be expecting. Elise, has anyone called 999? To be fair, yeah, I mean, members of the public do tend to do that, even though we're already on scene with everything. This is where the good working relationship with the NHS ambulance service comes in. The control room phone should be ringing from the ambulance service going, we've had a 999 call for an unresponsive casualty not breathing at your event. Are you already aware of this? Hopefully the answer is yes. If not, it's give us some details. Do you still have the caller on the line? Can you put us on the listen and we will ping you some questions as to what information we need to locate them. If we're already aware of it, we'll say, yes, do you want us still on the line or do you want us to call you back? Again, that working relationship with the ambulance service, depending on the size of the event and the resource level that's being provided, often determines whether we stay on the line or whether we'll get rid of them and focus on what we're doing. So let's imagine that you're a solo responder. So let's imagine that you've informed control this time that you are going to have a little bimbo on your own because you're technically going to, you're going to take your break. You're going to have a little bimbo. You go to the Mexican because you really fancy a burrito. And control gets notified as you're bimbling down there that there is a witnessed arrest, and it happens to be, 2 food vendors down from your Mexican. It's at the Indian instead. Knowing that you're already there, they're going to ask you to go, even though that you've left all your kit behind, because why are you going to carry kit when you're going for food? You've got what's in your pockets, you've got what's on your belt, however you carry your kit, that's up to you. You literally get dispatched with what is currently on or about your uniform. So let's assume that in the current climate, although it's unlikely we'll have events in the current climate, let's hypothetically assume you've got a type 2R face mask, you've got a pair of gloves, you've got an apron, you've got your tough cuts, you've got your JR calc, you've got your radio, you've got a pen, you've got a stethoscope, and you've got a few plasters and maybe the sheet of paracetamol and a notepad kicking around on you. But that's all you've got. You don't carry too much. You just carry little bits that you can give out to people who ask for silly bits. And you've got the things that you would carry whatever kind of shift you are. You are currently a FREC 4. You are on your own. So you arrive to this, and what is the first things you are going to do when you arrive on that scene? So lots and lots of people going with D or ABC, ABC, or the variations thereof. We've got some people checking what bystanders are doing, giving bystanders direction. So our first thing that we need to do is confirm they're in arrest. So if there is CPR ongoing, no more than 5 seconds off the chest. Really quickly, get in position first. Head down, ready to listen, watching those hands bounce up and down. Okay, stop. 4, 3, 2, 1, go. If you've not heard anything, you've not seen anything, we've already checked the pain response if CPR is ongoing, so let's not even go down the silly route of wasting time there. Because we've got our head down, we can check the airway while CPR continues. We can tilt that head back, we can have a look in it. As we're going down, we're watching the effectiveness of that CPR, and we're stopping just to confirm that there is absolutely no sign of normal breathing. Back on the chest. No more than 5 seconds for that interruption. Absolutely. So communicate what we've got. So we've done our checks and we've confirmed that quality CPR is ongoing. That's all we can do at this point in time. Communication at this point is key. Yet control unseen, call as given, out. And you're saying out because you ain't talking back to control now. You're busy. You need somebody else to come along and do those updates for you. Control know that. Control know you've confirmed that there is CPR in progress for an arrest. That's all they needed to know from you. They now know. Absolutely carry on with everything I've already sent. Is there already a defib, and can we get bystanders to do something? So, good points. If we, for some strange, crazy reason, when we went for food, we still happen to have our defib on us, what are we going to be doing? Get the shock delivered as soon as possible. Analyze or rhythm check, pads on. Who can remind me, where do we put the pads for any kind of defib? Where are we going to put them? On the patient. Well said, Patrick. Right shoulder and left hip, says Elise. So where are we putting these pads? Who can actually tell me what the Resus Council can say? Sorry, I can't see you on cam. I'm just going to bring up my screen of cameras. There we go, Chris. I can see you now. Go on. Yep, absolutely. The right clavicle and the left fifth intercostal space. For peds, it could be anterior and posteriorly. And if you want to go by what the Resus Council say, it is below the right clavicle and in the V6 position. So the V6 position is in the mid-axillary line on the left-hand side of the chest towards the bottom of the rib cage. Obviously, there is a particular intercostal space, but there is no way you are going to get a defib pad into an intercostal space. And they are self-adhesive defib monitoring pads. In the UK, we do not use paddles. We use self-adhesive defibrillation and monitoring pads. They are all exactly the same. They might have a different connector on the end, but they're all the same. You rip them out of the packet, you very quickly rip them off, stick them on. The point to check the date on the pads is not the point when you apply them to the patient. I have seen people dither and go, hang on, where's the date on this? No, I don't care. Put the pad on the patient. If it doesn't stick, throw them away, get the second set of pads out, stick that one on the patient instead. Dilly-dally and work out things like, was it in date and why didn't it work after your patient potentially survives. Don't waste time. Get on with it. That's the important things that we need to be doing right now. Obviously, keep a hold of the packet because we can record all that information later. Now, quite a lot of people spoke about the use of bystanders. So, bystanders, some of them may well already be doing some CPR, and that's absolutely what we want them to continue. Any bystander can do CPR, and the easiest thing to do, remember that Vinnie Jones advert, get on with it. If nobody's doing CPR and you have to start CPR, first of all, if nobody's doing CPR, you need to start CPR. The reason is you cannot quickly teach somebody to do CPR when somebody should already be receiving CPR. So bounce up and down, get straight on with that CPR, minimize the time off the chest. Now, make eye contact with a bystander, the one that's kind of hovering, who looks like they might want to help. Look at them, go, you, kneel down, opposite side to me. Watch what I'm doing. Look at how hard I'm doing this. Look at how fast I'm doing this. Do you think you can do this? You're just pounding up and down. You're not going to hurt them. So you're making sure you provide that reassurance to them. Okay, are you ready? We're going to change in 5, 4, 3, 2, 1, go. So that as soon as you lift your hands up, their hands go down. It might well be worth getting your hands straight back on top and pushing their hands down so they know the rate, the rhythm, and the depth that you're expecting from them. Because once you've done that, there's 2 more hands. There's 2 trained hands that is now capable of doing something else. It now means you can use that defib and have less time off the chest. It now means you can consider the airway. It now means you can squeeze the button on your radio. All of those are 1,000,001 things that you want to do but can't do when you're doing 2 minutes of CPR, you can now start to focus on. So yes, things like OP and NP. Now at this point, if we do not have a defib, only at this point, just to answer Patrick's question, only at this point do we now get a defib. The first and most important thing is to get quality CPR on the go. If I can shout at somebody while I'm doing that, go over to there and get the defib. So ProMed, we actually don't carry very much kit on us. We put kit into caches, usually near security points or key points where other event staff are. Because we can dispatch them without using our controller, because I can literally just have a controller shout across the control room and go, stewarding, defib, point 1, move it to that job now. And then we can then get straight back on and go, right, you move, you move, you move, HCP, you move. We can get all the staff in place, but we can have a defib there potentially before we get our own staff there. There's more stewards, there's more security, there's more site team and more production team on any event than there will ever be medics. If there is more medics than any of those, there's something probably badly wrong with that event. But generally speaking, you've got more other staff. So we put things like bags of oxygen NOx, defibs, carry chairs, possibly a longboard or a folding scoop in key locations, so that if it is needed in a hurry, we can get somebody else to bring it to us, or we can just divert our staff past the nearest one that they're going to go near to anyway. And that improves the kit to patient time significantly. If you come with the defib, it is still CPR first, then the defib. Because if you can get bouncing, you then have a choice. You can carry on with the bouncing yourself, and you can tell a bystander, open that case, get that silver packet out, rip it open, press that green button, shove that connector into that hole, stick that pad where it's labelled, stick that pad where it's labelled, just work around me, I'm carrying on. Or you can quickly train them and you can use the defib. But you can have both happening as a solo responder with bystanders. Don't wait until you're in that situation. Think about it at the start of your shift. Think about, right, if I'm on my own and I come across something, what am I going to do? What am I more comfortable doing? Am I more comfortable getting my hands on the chest, or do I think I can get a bystander to do that? Think it through. For me personally, I prefer to get somebody to set the defib up around me because I know that I'm doing the high quality CPR and then I don't have to check that. And because my eyes are already more or less going to be on the chest and I'm just scanning around the room, then I can watch that those pads are going into the correct place. And if it's an AED, it's shouting at me anyway, so I can hear that the correct things are happening and I can focus on the quality CPR. If CPR was already ongoing, I would just go straight for the defib and I would just watch the CPR and provide encouragement as I worked around them. So it sort of depends on what you do. Chris, I totally get what you're saying. If you're there and you've got the defib and you can see that someone's down and you're already opening that defib before you get there, then yeah, I can see the logic in doing that. If you're literally turning up to that and you've already got the defib turned on and the pads packet ready to snap open while you're confirming it, yeah, you're right. Pads, bang, 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 is 2 seconds. But if you've turned up and you confirm that and your defib is still zipped up in its case, what you think is 2 seconds is actually all of a sudden 15 to 20 seconds. And that's 15 to 20 seconds you could have been doing CPR and shouting at somebody to either copy you or open that box for you. It's very, very much scenario dependent, and you've got to go with what your gut says at the time. If you are truly, truly, truly on your own with no bystanders, yes, absolutely. You're going to have to, at some point, get the pads on. It's whether you decide to do your CPR first or whether you decide to put your pads on. That's a decision you make in advance and you stick with when you get to that patient, if you are truly on your own and there isn't anybody else within shouting distance. No problem, Chris. And yes, finding an AED. So if I've turned up, I'm on my own, but I happen to know that that there happens to be a defib just 100 yards that away, I will send somebody to go and get it. Even though control's dispatching people to do that as well, I'm still going to send somebody out to go and get me the nearest defib. If I'm out in public in a shopping centre or a town centre, I will send somebody. If I know where it is, I'll send them exactly to it. If I don't know where it is, I will just tell them to run down this street until you find a defib. Shout at somebody, you need a defib, and just keep shouting, somebody bring me a defib while you're running, because at some point somebody's actually going to go, there's one in this building, and you're going to get it. You've just got to tell people to keep shouting, be vocal, be noisy, let people know. Okay. They can also do your initial 112 and 999 communication. So it might be somebody's already doing that, especially if it's just two of you on an event or you're out in public. That might already be ongoing. If it's not, get that process ongoing. Get them to put the call on speaker and just say, I want you to tell the person on the other end of the phone exactly what I'm doing. Or if I tell you to say something, make sure they hear what I've told them to say. Or if I tell you, put that phone next to my mouth, that's what I need you to do. So you can, they can listen. They can, be told all the instructions about what to do while you get on and do your job. Because we all know a call taker who doesn't know who you are is still going to go through that clinical telephone advice and give you the instructions over the phone. You don't need to hear that. You need to focus on bouncy, bouncy, shocky, shocky. But your bystander will quite happily listen to that and go, yeah, no, he's already doing that. Yeah, no, he's got one of them. Yeah, no, he's already pressed that button. Yeah, no, he still is bouncing up and down. Yeah, you don't need to worry about that. Somebody else can listen and appease the call taker. So now we're looking at team leadership, because now actually we could have a little crowd. We could have some bystanders who are becoming helpful, or we could have our second team turning up, and all of a sudden we've now got some people and we now can do things. It's exciting now. We're not tied up on the chest ourselves. We're not kind of looking at that shock box too much. We now need to start thinking, how do I get the best outcome for this patient? And initially, with the caveat of, with the limited resources I currently have available. So what things should a team leader be considering? So what things, as the person who is going to run the arrest, is going to be in your mind? What are you going to think about with a patient? What are you going to think about with your responding crew? What are you going to think about in the wider environment? Throw some answers in the chat. Let's hear what you're thinking. So Neil's telling us to look at the timings and the T&H. Patrick, what happened? Dorota, do we need to swap the people providing CPR? Patrick, what was that history? Sudden collapse, chest pain, rest issues. Mick, the timing, the shock's given. Is the access clear? Is there a person at the door ready for the ambulance? Who's doing what? Taking the overview, that pit stop approach from Pete. Nathan, planning ahead, not just focusing on the immediate, because there's other stuff now doing that, and securing resources. Dorota, do we need to move the patient, or are they currently lying in a flood? Neil, what happened before the arrest? Human factors, drugs, reversible causes. Is the CPR still good quality? Do we have an airway with good air entry? Is the AED in place? Is everybody being effective? Does anybody need a rest? What times are the drug doses given? The reversible causes of 4 H's and 4 T's. So let's take a look through. So in my personal opinion, the team leadership role is the most critical role for immediate and advanced life support. Unless you have somebody calling the shots and making those decisions, then you actually could easily have a mess of people all wanting to do the right thing and all wanting to do their best by the patient. But what would happen is that story of somebody, everybody, nobody, and anybody. Anybody can do it, so nobody did it. Somebody could do it, but everybody did it. And that meant that nobody was doing the one thing that was actually important. If you remember that story, Google it. But without that effective leadership, without somebody taking the decisions over who is doing what and when, then everybody is doing their best. But inevitably, you will end up with duplication of effort, and you will end up with tasks that aren't being fulfilled. So in an ideal world where we have more than enough people around this patient who are trained and qualified and are appropriately resourced to do their job to the full extent of their ability, the team leader will ideally be hands-off. They will usually be stood. I say stood, they could be kneeling if this is an effort on the floor, at the patient's feet, looking up towards the head, watching what's happening in the middle, watching what's happening on both arms, with a clear view of the monitor screen. And again, in an ideal world where we have an unlimited amount of people at our disposal, on their right-hand side, in line with the major trauma kind of scenarios, on their right-hand side, they will have a dedicated scribe or logist stood next to them, or in the case of something on the ground, kneeling next to them. And I say dedicated because in the event world where we tend to be, manpower poor and, workload high, that scribe, if we do manage a separate one, tends to also be the person communicating with the external world. The team leader tends to, in the absence of a scribe, tends to be the team leader, the scribe, the person communicating with others on the ground, the person communicating with external agencies on the ground, and the person communicating with control and everybody above them. If we can separate that down, so the team leader is just looking at, communicating with other agencies on the ground, communicating with people around them, that's a great role. The scribe can be the scribe. The scribe can pass messages up and down. That's the ideal if we've got enough bodies. But initially, you're not going to have bodies. Initially, if there's 3 of you or 2 of you and a couple of good bystanders, this is the point where you can designate a team leader. Yes, the team leader is still going to have other roles to fulfill in that kind of human resource poor scenario, but at least you've now got a clear focal point. At least you've got somebody who is now going to call the shots, and that takes off that decision-making thought process from everybody else. That frees up their working memory. That allows them to think a lot more about the roles that they've been given, and therefore not having to get confused. Yeah, TL would have a CPR checklist. Funnily enough, we are actually developing our own CPR checklist based off NHS ambulance services, because they are very useful. That challenge response kind of list in an ideal world, but in an arrest scenario where you don't have enough people to do that, literally a tick list, like, have we got pads on? Have we got a second set of pads ready? Have we got this? And so on. Yes, please, if you don't mind, Chris. We've got one from another ambulance service in the nearby vicinity to where yours is. But I would like to compare multiple ones, and then we can develop our own ProMed one in line with what is a consensus across everybody. And you're absolutely right, the team leader does not have to be the highest clinical grade. In fact, if you've only got 1 or 2 HCPs, the last people you want to be your team leaders are HCPs. And we're going to look at why that is when we come on to their roles. But actually, a good team leader, you can have an excellent team leader who is a FREC 3. You can have a good team leader who is an ambulance technician or a FREC 5. You can also have an astoundingly poor team leader who's a doctor, a nurse, or a paramedic. Team leadership is based on interpersonal skills, not clinical qualification or professional register. And because of the fact that there are certain skills that are needed in the rest that only registered professionals can use, then what you tend to find is HCPs should never be a team leader unless you happen to have ended up in that scenario where you've got a double paramedic crewed ambulance that happens to have a third paramedic observing, is backed up by a paramedic RRV, and the leading operations manager who's in tow behind is also a paramedic. Only in that scenario would you consider using an HCP as your team leader, because you ain't got anybody else, basically. But if you've got anybody else other than your monkey who's bouncing up and down on the chest, and I go back to, we have bystanders who can do that for us, should you kind of not have a low clinical grade as a team leader? And Chris, you're absolutely right, ECAs can lead plenty of arrests. And their role is to deploy their team effectively based on their skills. So this goes back to what we did at the very beginning. Before we even went operational, who is who? What skills do we have? Who's registered? What experience do we have? So that team leader just needs to look around and go, yeah, right, you're the paramedic. You told me you'd done some arrests last month. You told me you're green as grass and passed your qualification last week. Bouncy, bouncy, please. You know, worst case, you've just got to quickly go, remind me, what are you? Right, what are you? What are you? Okay, now I want you to do this, you do that. You might need to swap some people around, and you might need to kind of have that, 5-second kind of who's doing what. But all the time, CPR is still ongoing, the defib counter is still running, so you're in a position where you can do that. And actually, that 10 to 30 seconds of quickly capturing everybody's skill and deciding what their role is going to be is a worthwhile investment in time, because you're now using everybody's skills and experience as effectively as possible, and that is going to improve the patient's outcome. Getting somebody to do a task that they are certainly able to do, but that is preventing them from using their higher skill set or their knowledge and experience when nobody else can do that, is going to not give as good an outcome for that particular patient. What else do we need to do? We need to ensure quality CPR. And the way we do that is to plan the actions before pausing and communicate them to the team. So our goal is continuous quality CPR with a minimum time off the chest. The RC UK guidance here is no more than 5-second pauses for any intervention, whether that's an AT tube, whether that's a rhythm analysis, whether that's a shock, or anything else at all. No more than 5 seconds off the chest per intervention. So you're looking at that clock, you're looking all the time, and you get 1 minute 30. Okay, I've got 30 seconds left. When we pause for a rhythm analysis, everybody will stand clear. The person currently doing CPR will continue doing CPR as soon as they are instructed. You are going to be ready to move in at the shock, and you are going to take over CPR. If we decide to go for a shock, you are going to press the button to deliver that shock after you have charged a defib. If we do not deliver a shock, I will call swap, and we will swap CPR at that point. Make absolutely explicit the instructions you're going to give, and be absolutely explicit on what those command words are. So when it comes down to it, you're going to watch that clock and you're going to go 5, 4, 3, 2, 1, pause, rhythm, and then you will either call swap or charge. One word or the other. But people need to know 3 words for that moment. Pause, which is when somebody's going to check the rhythm, and then either swap, because it's an unshockable rhythm and you need to change the person doing CPR, and then charge, i.e. the person who was doing CPR is going to continue, and the person who's operating the defib is going to press that charge button. The only other word then is shock, and it's going to be the person who is delivering that who is going to go, everybody clear, off the chest, shocking, go. That quick. From off the chest to go should be no more than 5 seconds. We're minimizing the time off the chest, and the way we do that is we decide who is doing what and making sure that everybody is in the right place before it needs to happen. We give very clear countdowns, and we use single, clear command words, ideally single syllable command words. Which words did I choose? Pause, 1 syllable. Swap, 1 syllable. Charge, 1 syllable. Clear, 1 syllable. Shock, 1 syllable. They are just single, direct keywords. And the team leader is going to make sure that we consider the reversible causes and ensures that they're corrected. Now, if the team leader is not the most clinically skilled, the team leader can read off the checklist what those words are, and the most clinically skilled person, whatever they're doing, can then start to verbalize what needs to be checked. And as a team, you can do those checks together, because an HCP who is in the middle of cannulation, team leaders going 4 H's, hypoxia. HCP can just carry on going with what they're going on with and go, right, oxygen, have we got SATs on, have we got oxygen running? And that can then be checked by somebody else. So just because the team leader is not clinically qualified and might not know what all of those 8 words mean, there are going to be people who do, who can input. So communication, that's the next most important thing after the team leaders. Now, I'm just going to read out some points. Chris, SGA for continuous compressions, Dorota with the filter, SATs, always don't want to mess up the end title side of the monitor. So there are things, and we're going to look at them as we come into what people are going to be doing. So if you're not a frontline crew and you're not in an environment where you have an event medical control, 112 or 999 straight away, get that in, get an open line, get them on speaker, because then control now knows exactly what's happening on the ground. If you are a frontline crew, get a hold of dispatch. Are you on airwave? Press the button. Are you using a mobile phone? Find that number, ring it, get that line open. Because if you're arriving when you're tasked to a job, the person at the other end needs to know what you have. If you have a confirmed arrest in front of you, they need to know that you have a confirmed arrest, because they will then start activating more resources to get to you. If it's still a suspicion of, you might only have another resource running, and it might be running from the other side of town. If they know that it's a confirmed arrest, they might pull somebody off an auto dispatch and get them to you instead because they're closer. They might well go, I'm going to send a 3rd resource because this doesn't sound too clever. Every resource that arrives at a job like this needs to report the situation as they arrive. Arrests can be very, very, very fast moving. The first crew on scene might arrive to a peri-arrest. The second crew on scene now arrives and CPR's ongoing, but the first crew never had the chance to call that in because they're now too busy, dealing with the situation. The third crew arrives and they obtained ROSC a minute ago, but nobody's had the chance to call it in because everybody's still busy with their actions. So every time a resource arrives, they still need to call in the situation that's in front of them, because that's keeping control updated. That's giving them that information they need. They know the scenario on the ground, right? Do I need to get more security because actually it's still quite crowded down there? Am I going to need traffic to get a route clear because actually it took them 5 minutes to move 300 yards? That shouldn't have happened. If you don't know when that resource has arrived, you don't know if your vehicle route in and out or your foot route in and out or whatever it might be is in any way, shape or form compromised, because you're still assuming they're traveling, or you've assumed they've arrived, but you don't know whether they arrived after 30 seconds or 10 minutes. So that reporting on arrival is absolutely vital, because you are the eyes and the ears of that control room. So they need to know what you've got so that they can support you. And that'll build up the picture. Is it improving or is it worsening? Right, if it's worsening, right, critical care paramedics, HEMS, doctors. What have I got available that might get there? Situation's improving. Right, okay, I probably don't need the 4 foot foot teams that are now jogging halfway across site. I probably just need to keep one more running just to provide them with a bit of relief, and I can get everybody else to go back to their posts. So knowing whether something's getting better or worse affects what resources you're going to be sent. Oh, the situation is improving. Right, well, now might be a good time to start thinking about sending the ambulance as close as possible to that patient because they've got ROSC. There's no point sending an ambulance to sit and wait with a crew that's not really going to be in a position to do anything above and beyond the 6 people you've already got on the ground. And there's no point in blocking a traffic route because when the ambulance then needs to leave, it might find itself in a difficult position trying to get out. So knowing all of these things going on the ground allow control to kind of preempt what needs to happen and get things in the right place at the right time, not too early, not too late, not too many, and not too few. What non-healthcare resources do we need? So if we're in public, do we want the water fairies to provide a nice, lorry-size barrier to prevent people from seeing what's going on? If we're on an event, do we want to get a dozen stewards to form a line and hold up some blankets to give this patient some dignity and create a safe working area for us? If we're in the treacherous mud at the back of an event, do we want to get one of the site buggy drivers to come and give us a hand getting this patient moved out when we're done? So what resources that aren't necessarily part of our own team are going to benefit the overall situation? Team leader can consider these, control room can consider these. If you're the solo and you happen to have an open line and you can shout at it, you can just shout out what you're going to need. So what can non-HCPs do? So we've already had a good few suggestions. So HCP, for those not initiated yet, HCP is a healthcare professional, and by that I mean a registered healthcare professional. So in the UK, I mean a paramedic, a doctor, a nurse, a midwife, somebody of that kind of calibre. In Ireland, I will be referring to an advanced paramedic, and I'm not too sure how it works in America. So what can these non-registered, they're still healthcare responders, they're still first responders, they might be technicians, but what could we expect those kind of people, right from your BLS, right up to your kind of ILS and your ambulance technicians or your emergency medical technicians, what things can they do that is going to improve the outcome for this patient? And what resources are they going to need to be able to make that happen? Throw your answers in the chat. So partially right from Elise, you would keep track and you would monitor the timings, but non-registered staff should not be doing any kind of medication for an arrest. CPR, overseeing and welfare, providing blankets, running the event log, being part of that CPR team and logging, dealing with the family, getting a basic airway in, logging the meds, yes, no, that's absolutely fine. The only drugs that we can give in an arrest scenario, there is one single exemption in law that would allow a non-registered professional to be able to give them. And that is somebody who is a certified advanced life support provider can give the 2 drugs in question. But otherwise, it's paramedic, doctor, nurse, midwife in the UK. Mick, yeah, put the coffee on and we'll look at that at the very end. That is actually, it sounds silly, but it is actually an important step. It is something that does need to be done. So first thing, focus on quality chest compressions. Have we got feedback devices? At ProMed, we use the Philips MRX and we have the QCPRs on all of them. There are other commercially available feedback devices available. If we have them and we have somebody spare who can quickly whip it out and get ready to put it in at the next changeover, then we'll do that. We wouldn't interrupt CPR just to put a CPR feedback device in. We would wait until we are next going to pause that CPR for another reason, and then we put the feedback device in. It's part of an overall package of care, but it is not the be all and end all. Just because it is there doesn't mean you have to whip it out and use it. They're going to minimize the time off the chest. So like everybody else, they're going to plan their time effectively. They're going to work together as a team and minimize the time off the chest. They can use appropriate airway adjuncts up to supraglottic airway devices. That doesn't mean to say they have to whip it out and stick it in first of all. A stepwise airway management approach is just as important. Head tilt, chin lift, jaw thrust, using a bag valve mask and getting a really effective seal with that mask. Inserting an oropharyngeal or a nasopharyngeal airway if indicated. And yes, if an eye gel or a laryngeal mask airway is indicated, then if they're trained and competent, they can use that. And if they are trained and competent, then one would argue in an arrest, it is an appropriate intervention because, as Chris alluded to earlier, then you would want to have asynchronous ventilations and compressions because that's minimizing the time off the chest. Chris Hall, you're absolutely right. The Zolex series pads have them fitted. There's a couple of other pads out there that you've got the pad, and it's got like a little, you know, connecting like piece in the middle. And yes, when you're putting that down, that's getting your feedback device in, but you're having to interrupt the CPR to get that particular type of pad on the patient. You're not stopping just to put the bit in the middle down. You're stopping to get the pads on. So it's a slightly different reason why you're stopping. And yes, you're absolutely right. If a Lucas arrives, take the device off the chest. Yes, if you want your £200 Bluetooth Lardal QCPR device to become nothing more than 100 little mini electronic pieces, by all means, leave it on. Personally, I like my expensive QCPR devices in the current shape that they are with a working screen. Yeah, remove it. If you're going to put any kind of automated device that is going to deliver the high quality CPR for you, remove all of your feedback devices from the patient first. It does sound obvious, but you're right, Chris. Somebody somewhere will do it. High flow oxygen at 12 to 15 litres per minute and SpO2 monitoring. So even if you just happen to have a cylinder of oxygen with a medium concentration mask, you can still run 15 litres through that mask over the patient's mouth. Some of that is still going to get in the patient's lungs because every time you're bouncing up and down, you are shifting air in and out of that airway. It's not ideal, but you know what? It's not doing the patient any harm. What is doing the patient harm is hypoxemia. You know, high flow oxygen through a medium concentration mask without a bag valve is not going to radically improve their outcome, but it certainly is going to harm their outcome. Ideally, you want a bag valve mask to start with, and then you want a bag valve and supraglottic airway as quick as possible. And we want SpO2 monitoring. It is in the RC UK guidance that to check for hypoxemia, you do need to be looking at a SATS probe. So your cardiac monitor will have one of these. It's an afterthought. You know, focus on the airway, the breathing, the circulation, that defibrillation. But once all of that's up and running, then start and open up all of your little bits and pieces and start putting the other cables onto the patient when things are running smoothly. End-tidal CO2 monitoring. Now, this is the godsend. You can put end-tidal CO2 monitoring in line with any 16, 17 mil connector. It doesn't have to be a supraglottic airway device. If you've got a bag valve mask, that bit between the valve and the mask will take an end-tidal CO2 little piece that samples it. And when you're holding that mask getting an effective seal, you will still see that waveform on your screen from an end-tidal CO2. It can be used, absolutely. If we can get a supraglottic airway device in there, we'll make sure we put it as part of our airway tree. But it can be used with other things as well. It doesn't just have to be the Gucci stuff all in one go. If you've got a monitor there, but you haven't got all the airway stuff, or you've got a monitor there, but you aren't trained to use an eye gel, then that's absolutely fine. If you're in a situation where somehow you've got a cardiac monitor and a pocket mask, you can even stick the end-tidal on the end of the pocket mask. It will actually fit. And if you're holding that mask down and getting a seal, then it is still sampling the patient's air as it moves in and out. It is showing that you are providing quality CPR, because end-tidal CO2, as well as being one of the earliest indicators of ROSC, is also something that can be used as part of your quality CPR feedback. Read the guidance, read the clinical literature yourself. I'm looking at the operational side of it. BVM and Untitled, not the best way, unless you're ensuring it's picking up ambient readings. But to be fair, there's so little carbon dioxide in the atmosphere, it basically doesn't detect them. They should, if they've been calibrated properly, be calibrated against atmosphere anyway. So that what you're seeing at the bottom is just the bottom. It's not going to give you the same rise as you would get as part of a closed airway circuit, but you are still going to see some rise on your screen. It's not going to be the great big, waveform that you're used to seeing when it's part of a closed circuit, but you are still going to see some CO2 coming out as it should do. You don't get ambient clutter readings of CO2 because there's only 0.05% CO2 in our atmosphere, whereas in theory we're expelling 5% CO2, so there's a factor of 100 difference, which is statistically significant. So even if you're only picking up half of that, that's still a factor of 50, which is still a statistically significant difference. And non-HCPs would be assisting the healthcare professionals as appropriate. They would also be assisting the team leader as appropriate. So now let's look at HCPs. So we briefly spoke about these things. So yeah, you're right. In a controlled environment, in a house where everything's managed and you've turned up as part of a crew and you've got all the kit readily available, then absolutely, you're right. But sometimes, the kit might not arrive in the order you want. Somebody might have, you might have the HCP solo responding with their monitor and drugs. The airway stuff hasn't yet arrived. It's going to arrive in a couple of minutes, but you use what you can when you can, depending on what resources you've got available. My overall point is, that it's two-sided, actually, two sides of this coin. Don't use the Gucci kit just because it happens to be lying around, but also just because you don't have every single thing that you were expecting to have from your training doesn't mean you can't use part of it as part of your intermediate measures while you're waiting for everything. So, HCP tasks. When our HCPs arrive, what do we need to focus on? Well, our HCPs need to be getting IV access, the largest possible, and depending on your trust guidelines or what research you've done, that may well be 2 IV access. It might be 1, might be 2. At the end of the day, your HCPs, you're autonomous, you decide on what's appropriate. But ultimately, as a team leader, as somebody looking at the operations side, the first thing I want you to do, if there are already people doing the CPR, the monitoring, the defib, and the team leading, is getting the access. If there is no IV access, then IO access, absolutely 100%. Untitled without filter can mess up the ET side of the monitor. So we shouldn't be using any kind of mask without a filter. I'd be a bit worried if people were using a pocket mask without a filter, because they should all come with filters in them. If they don't, well, A, you're being sold something very, very cheap. But B, why are you putting your mouth near it? Please don't. Everything should come with a filter these days. Second thing that an HCP needs to do is get the adrenaline ready to go. Now, a little while ago, there was a shortage of pre-filled syringes. So most people are now back to having pre-filled syringes, but not everybody is. So let's be clear. Adrenaline and cardiac arrest is 1 in 10,000. So you need 10 mils of 1 in 10,000 IV ready to go. If you are using a small glass ampule, you do not put that into a patient's vein. If you see anybody draw up straight from an ampule and about to put it into a cannula of somebody in arrest, stop them. Just stop them. You might not be qualified to give that med, but you are more than capable of knowing that they shouldn't be doing something, and you are as entitled as everybody else to challenge them on something that you think is unsafe or inappropriate. It might well be that they just got caught up in the moment, remembered they needed adrenaline, didn't have a pre-filled syringe, got the adrenaline ready, and it's happened. It has happened in so many different environments. I don't think there is any NHS trust where they didn't report this at least once. Some trusts reported it multiple times and paid an extortionate amount of money to have the pre-filled syringes. Absolutely, Chris. The Crash 2 trial, which involved, off the top of my head, 3 NHS trusts across the UK on the efficacy of adrenaline in cardiac arrests, basically didn't come to any real valid conclusion. My recall of reading the paper was that more people survived to hospital discharge, but no more people survived to hospital discharge in a functioning state. So the number who came out and were, able to, lead a, shall we say, relatively ordinary life was more or less the same number, but adrenaline meant that more people survived to hospital discharge, just albeit not in the same, not as kind of, able to lead a normal life. Yes, that's it, with a reduced quality of life. Thanks, Elise, for correcting my wording. So your jury is still out on adrenaline, and I dare say there's going to be some more large-scale randomized trials on that. But at the moment, if you are going to follow the Research Council UK guidance, it is still in there that after the second unsuccessful shock, or if you're on the non-shockable side of the algorithm, you would give 1 milligram of 1 in 10,000 adrenaline IV, and you would repeat that after every second shock. So you're going to need that ready to go. I'm not saying open all of the packets and break the tamper seals and unscrew the ends. What I'm saying is open the bag, get them out, lay them out on a line so they're ready. So we're not messing around every 2 minutes going in and out of the bags. Next thing, amiodarone, 300 milligrams IV, ready to go. We only need 1 of them. We only give 1 dose of amiodarone. Again, if we're still early in the sort of process and we've not yet gave the second shock, we're just going to get it ready to go. We're going to have that box out next to our first box of adrenaline, so it is ready to go. We don't want to be fumbling around trying to find stuff in bags. This is something a non-HCP can do, actually, is open a bag and find the relevant drugs ready while the HCP is getting the IV. It's still second shock. Sorry, I'll need to check the guidance. I've not got the RC UK guidance open in front of me. I will defer to, thank you, Chris, I'll defer to those who do have it available. And flushes. You need a huge amount of flush for an arrest. So again, this is the HCP's discretion. So the guidance from the RC UK says you need to flush with a minimum of 20 ml flush for each drug dose that's administered, and you need to raise the limb if it's being administered peripherally. So 2 ways to do this. You can have lots of either pre-filled 10 ml syringes ready to go, or you can draw up a load of 10 ml syringes. Heaven forbid you're in a really good scenario and you happen to have 20 ml syringes, use them, but not many people do have 20 ml syringes these days. So get your 10 mls ready to go. If it's pre-filled, leave them in the packet so they're ready to go. But if you're having to draw them up, get at least 4 drawn up and get some more drawn up so that they're ready. If you're working on 5 mls, dear me, you're going to be going for a while, aren't you? The other option is to use a 250 ml bag of normal saline infusion with your given set connected and run that. A decent sized squeeze, is about 20 ml. If you want to measure it, then absolutely, you can take a bag of saline, the 3-way tap, you can twist your tap, draw 20 out, twist your tap, push 20 in, and you can manage it that way. I've seen that done with glucose. I've seen that done with saline. It can give you an accurate measure. I also have seen water fairies be told, give that a good hard squeeze now, please, and let the pressure do it. Again, it's the HCP's discretion. They are the ones who are responsible for administering the drug and signing it off. As long as that 20 ml is being achieved, that's what I would care about as a team leader. How that individual HCP chose to go about delivering that 20 ml is their autonomy. It is their individual professional decision. Whatever decision they make, I would expect those around them to support them in getting stuff prepared. Chris, 20 mls may well be standard in your particular ambulance service or trust. Certainly the trusts where I've worked frontline, if you could find a 20 ml syringe, you were having an extremely good day. And it was the one 20 ml syringe that you happened to find, and you were having a good day. I never once came across more than one in a drugs bag, put it that way. And the other thing an HCP can do, if it is required, is endotracheal intubation. Now, again, the jury is very much out on that particular skill. There are certain trusts that do not allow anybody other than advanced critical care or specialist paramedics and doctors to do that, and they're required to do 6-monthly competence assessments. Other trusts allow paramedics their own autonomy, and they decide, are they maintaining enough competence to do it safely. RCUK, they say if you're going to do ET intubation in the field, you need to be practiced and you need to be an experienced, competent practitioner in order to do it. According to the RCUK, ET intubation is again a 5-second interruption to CPR. So you should be doing all your laryngoscopy. You should be getting the cord just above the cord. You should be getting the tube just above the cords. Cricoid pressure on, pause CPR, pass the tube through the cords, pressure off, CPR on. And then obviously you would then check that the placement with your stethoscope at the next time you would give the 2 effective breaths. You're minimizing the time off. But yeah, ET can diminish, airway becomes a focus. There are so many reasons why there are people out there saying don't do it. But at the same time, there is also a huge school of thought that ultimately, if you get ROSC, they need to be on AT because they're going to be vented. So why not do the AT as soon as possible? Or, you can't vent effectively through supraglottic because the pressures are too high and you don't get the seal. And if you're going to try and get the best possible thing, you want an automated device. So there's 2 schools of thought. I'm not a registered healthcare professional. I may have my own thoughts and opinions, but actually the person who is going to be responsible for making this decision on the ground is the registered healthcare professional. So as a team leader, I would always defer to their professional judgment, and whatever they decided to do, I would ensure the team supported them and helped them to achieve what their goal was. Pre-hospital intubation is a rescue airway using a bougie, because there's time off the chest. End-tidal CO2, absolutely end-tidal CO2. And some patients could be first line, so pregnant, asthmatic, and so on. Do we do a second dose of adrenaline in the UK? Not according to the Resus Council UK guidance, you don't. Chris, it doesn't surprise me. I mean, in Thailand, you can do pretty much anything you want there. They're certainly used to sticking things in people's throats in Thailand. So now let's move on to the aftermath. Once Chris has refocused and composed himself, the rotter also. Thank you. Okay, we're a bunch of healthcare professionals. We always lower the tone, of course we do. So aftermath. Neil, absolutely, I go in bareback, as big as possible, straight in. So aftermath. So this can go one of 2 ways. We can have an arrest where we get ROSC and we safely transport them off to an appropriate receiving facility. That may not be the nearest ED, that may be an appropriate cath lab, it may be another particular specialist centre, depending on local requirements and what the trust are telling us to do. Of course, it could be something else. It could be that we are awaiting the arrival of the constabulary and the black van that says private ambulance down the side. So we don't know how this is going to go. And actually, we have to be prepared for both sides of it. So whatever the outcome, we are going to be completing our patient clinical records. So our patient clinical records is going to be our standard patient report form, as we would for every single patient interaction that we have. If, however, we have decided to cease the resuscitation effort because we have, either unequivocally recognised a condition incompatible with life, because we have recognised that life is extinct, or because a healthcare professional has, stepped up and certified it, then there's going to be a witness statement to complete. So A lot of trusts and ambulance services have a recognition of life extinct witness statement, and that basically is a pro forma that says at a certain date and time, we recognise life extinct because we carried out the following checks, and this person is signing to say that they are responsible for doing all of these checks, and they did not find any signs that were compatible with life, and so they took the decision to cease the attempt. So that form might need to be filled in. If there's any checklists that we've used, we're going to make sure they're filled in. If we've used any drugs, we're going to be making sure that we fill in the drugs log from wherever we took the drugs from. And before we turn off the monitor, we are going to find that button that says print. We're looking for, print code summary. We're looking for print patient report. We're looking for print arrest summary. There will be some kind of report that your monitor will produce. Code summary buttons. Some of them transmit those straight up to a central server. But in any event, you'd want to be printing this off. Either it's going with your witness statement in the envelope, or it is going with the patient clinical report form to whoever you're handing over to, because then they may not have immediate access to your electronic records. So get that printed. Usually we tend to say print 2 of them, one for your records, one for the handover or witness records. But we need to make sure that all of our paperwork is tidied up and boxed off, and preferably we need to do that before we leave the scene. So if we've got ROSC, I would generally say while you're having that 10 minutes, allowing your patient to stabilise, letting the myocardium kind of stabilise and get into a stable rhythm before you start jostling them about. This is the opportunity where you can go, right, what have we just done for the last 15, 20 minutes? What have we gone through? Before we throw all of this stuff in the general waste or the clinical waste, what batch numbers have we used? What's the expiry dates and everything? Let's get all this recorded now. Likewise, if we're moving them onto a truck, then, before we start driving off to hospital, because again, if we've moved somebody, jostled them about a bit, their rhythms might well just go a little bit haywire for a few minutes. So we'll just let them settle down again. We'll do a little bit more paperwork before we go. So just because we're not rushing somebody off to hospital doesn't mean we're not doing our best for the patient. It actually means we're taking the opportunity to give the patient the best possible chance by giving their body that chance to just rest and stabilize itself, and we're using that time to be ready. Dorota, again, I'm speaking about the operations, not the clinical, and there are several schools of thought and several academic papers about active cooling. I'm sure our registered healthcare professionals on the call or our student HCPs have got some opinions, and we're more than happy to provide a little bit of time to discuss them. We need to restock the equipment. So we've got a lot of different things that we'll have used. A set of pads, various airways. We'll have almost certainly run out of a cylinder of O2, if not more than one. We may well have used some stickers, some ECG electrodes. We may have got blood all over stuff. We'll have used our PPE. Our cardiac monitor batteries might be a little bit low. If, God forbid, we're using a LifePak CR Plus, then we need to replace the battery on it after we've used it for a single patient. We might well be absolutely covered in sweat. Our uniform is part of our equipment, so that needs to be restocked. So we need to make sure that before that equipment goes back out into operational use, it's restocked. There's no point in going to the next arrest if your AED now no longer has a set of pads in it, because it ain't an AED that's going to help that patient. It's a door wedge. So whether it's a case of you take it somewhere, you put it down, you pick up a fresh machine, or whether you go somewhere and you pick up the parts that you need to refill yours with, make sure you know in advance what those arrangements are, so that your aftermath procedures are as short as is reasonably practical, but not forgetting the importance of yourself. So a hot debrief. So everybody who is involved in the arrest should take a few minutes together, because whatever the outcome, there is something that you are going to need to talk about. Vishwanath, yes, the webinar is being recorded and it will be available on YouTube tomorrow. Chris, thanks for the JR Calc stuff. So yes, Hot debrief. Yeah. So as Mick says, this is where you go and put the kettle on. This is, where you get away from the scenario. You might go to the hospital brew room at the back of the ED. You might go back to station on an event. You might just go back a house and grab a drink, and you talk to the people who were there. And good or bad, everyone just has something to say. Yeah, bystanders and the family. Especially if you've involved bystanders in providing some of that care, they need to be included in your hot debrief. They need to be brought back of house with you. They need to be brought away from where everybody is, and they need to talk exactly the same as you are, and you need to facilitate that space for them. So, make sure we have that hot debrief. Make sure everybody gets time before they get deployed to their next patient. And then have a follow-up for trim. So 2 to 3 days later, you need to check in as an operations manager, not involved, that is. You need to check in on your team leader. You need to check in. You need to make sure you've accounted for everybody who was involved in that job. And you need to give them a quick phone call. It might well be just a quick phone call. Hi, how are you doing? I know you had a tough job a few days ago. You all right? Yeah, you've been out on a few jobs since. You still happy? You want to talk about it? Yeah, okay, no worries. Lovely jubbly. It might be that they go, no, I've not been out. Actually, I've just been at home. I've been on my own. That I'm playing it back in my head. Okay. Do you want to speak to our employee assistance program? It's free. It's confidential. I'm not going to know what you talk about. Do you want the phone number? Whatever that is, we just need to make sure that 2 to 3 days after that kind of scenario, that incident, that occurrence, whatever we're going to call it, we just follow up with those people. Just a little check-in. Quite a few people are just going to go, was a job. I remember the last arrest I did back in September. It ended up being a Perry, and we ended up getting them in, and they arrested when we got them in. But I was like, well, it's a job. We delivered them. Heart was beating when we put them through the door. Job's good. Phone call a few days later, I went, well, we did what we did. I'm all good. But I also know that some people have done some jobs where they've been the same age as a family member, or where they did their very best but didn't get a successful outcome, and it's really hit them hard. And that's not any reflection on them as an individual at all. That's just because as human beings, we have emotions, we have thoughts, and we have behaviors and actions. And as part of being human, different things will affect us all differently. ProMed, we are currently going for Mindful Employer because we genuinely do care about our staff's mental health. All of our leadership team are level 3 supervising first aid for mental health trained, and we are looking at offering mental health first aid courses to some of our staff as well, because we do take mental health seriously. And whether that's they may have done an outstanding job and got an amazing outcome for a patient, but actually, because of something else that happened to them 2 days ago in their personal life, it's just, added to a little bit of anxiety that they didn't realize they had. And again, we're all human. That's not a bad thing. And we wouldn't say, okay, well, you're not working for us for a few days until you sort yourself out, man up. We're not like that at all. We're going to go, okay, do you want to be on shift? Do you not want to be on shift? You tell us and we'll make that happen for you. We genuinely do care about people's mental health. And good service providers, good organisations will care about people's mental health. Chris, I'm afraid I don't have access to trim training. If there is a nice, affordable solution you're aware of, I would very, very, very much love to. Debriefing is critical. Explore the job afterwards. Talk through the chronology. Helps to organise the events, and then you can reflect and process, and that delayed review as well. Yeah, absolutely. It is good. I like to run through what happened in order, especially and doing the paperwork, because actually when all of this has happened, if I've not had a scribe or I've not been doing the scribing, then trying to remember what happened when and in what order, it's a jumble in my head. I remember everything that's happened. I don't remember what order it happened in. And again, I know other people who are like that. I also know other people who always remember the order things happened, but perhaps they don't remember everything that happened. They just remember the order of the things they remember. Everybody's mind works differently. And by sitting down and talking it through together, you can collectively kind of process that. So that is the webinar, all 90 minutes of it tonight. So thank you everybody for staying. We have overrun by half an hour tonight. I'm not going to apologise. It's a free webinar. You've had exceptionally good value for money. We have talked about the pre-arrival, what to do as a solo responder, the use of bystanders, the importance of team leadership and communication, what non-healthcare professional crews can do, the tasks that our registered HCPs need to focus on, and what to do in the aftermath of that particular type of patient. So I'm sure many of you still here would be interested in receiving a CPD certificate. If you would like one, please send us an email to webinars@promed999.co.uk with your full name. We will verify that you were in the session throughout. So if you email from a different email address to how you've connected to Zoom, please tell us the email address you logged in with. And likewise, if the name that appears in Zoom is not the name you want on the certificate, please tell us the name that you want on the certificate. We are going to verify that you've left us a review on one of the many reputable review sites, and we'll email you your digital certificate within 3 business days. So on the basis of the reviews, one of my admin team is being absolutely outstanding and putting the links in the chat. So the webinar has been provided free of charge. So as a little gesture of thanks, if you wouldn't mind, please leave us at least 1 review. We use Trustpilot, Yell, Google and Facebook. All of those links are in your chat. If you've already reviewed us on one, please feel free to review us on one of the other ones. If you've reviewed us on all 4, thank you very much. We already know that. You're welcome to leave us a more up-to-date review, as it's probably been a few weeks. But if you don't want to, that's absolutely fine. You're obviously regular attendees and you've already kind of gave your thanks, and that's absolutely amazing. We really do appreciate I think we've got 250 reviews collectively across those 4 sites now. So thank you everybody very much who has reviewed us. I'm going to open the Q&A session. So I'm just going to have a little flick through what people have said. So Chris, Dorota, Bethany and Thomas, you're all very welcome. Might have a blue light program. That's actually interesting. I will have a look for a link to that. Chris, yes, thank you very much. This was your suggestion. Do feel free to suggest any more. Amy and Kiani, you're very welcome as well. Nathan, yes, our little hiatus over Christmas. These are going to be probably fortnightly now. And yes, patient management, we do look at the operational aspect of that. Gavin, you're very welcome. Annie, absolutely, it has flown by. I'm operational first thing in the morning, as Chris well knows. I'm coming to his first thing, crack a sparrow fart. So I would like to get to bed, but I do, genuinely do see the value for my own practice in preparing and delivering these webinars, but also for your practice in listening to them and contributing to the Q&A. So I'm in no hurry to end this session at all. Gavin, Patrick, Abigail, Mick, and Danny, you're all very welcome. So if you do have a question, please feel free to put your question in the chat there. If you would like to ask a question verbally, there's a button in Zoom where you can raise your hand. If you raise your hand, that'll flash up to me and I will ask you to unmute yourself and we can have a verbal conversation. Let's have a look. Danny, Colin, Elise, all very welcome. Chris, no problem at all. David or I will email you before we go to bed. In the very worst, you'll be getting a sticker and a request form with the patient's name and address on it when I see you in the morning, but I am planning to actually send it to you before I go to bed. I'm having to type it anyway, I may as well put it in your email. Yes, David will reissue your critical workers letter for tomorrow as well. That's not a problem. So other than the operational aspect of the business that me and Chris are discussing, does anybody have any questions relating to the operational side of running cardiac arrests? Celia, may I ask, how do you get CPD? Okay, we've already gone through that. I'll go through it again if there's no more questions though. Anybody have any questions about it? Thank you, ProMed admin team. Any questions at all on tonight's material? Going once, going twice, and gone. So thank you very much for staying. If you want your CPD certificate, please email webinars@promed999.co.uk with your full name. We'll verify that you've been in the session throughout and that you've left us a review, and we'll get your digital certificates emailed within 3 business days. Leave us a review on Trustpilot, Yelp, Google, or Facebook. The links are available in the chat. If you've already left us a review on one of those sites, please do leave us a review on one of the others. So thank you very much for attending. Our next webinar is going to be on the 21st of January. Next week I am operational on Thursday, so I won't be able to present. But on the 21st of January, we are going to be looking at how to correctly don and doff level 3 PPE. I'm debating whether I'm going to do a practical demonstration as well as the theory for that. After that, on the 4th of February, we have a safeguarding webinar for event medical providers. And then after that, we are waiting for suggestions. So MSK? What do we mean by MSK? After that, we don't have any webinars planned out per se. We are awaiting suggestions. So the 31 of you still in the chat, if everybody comes up with their own suggestion, that would more or less take us till October this year. Musculoskeletal, that's a clinical thing. We might ask STC to run one because they are our clinical experts. We like to focus on the operations and logistics. I'm thinking of one on the legislation surrounding COVID-19 testing. Might well be a good one to do in mid-February, actually. But beyond that, yes, there are sexual assault. Yes, Chris, I will do one on sexual assault, actually. That is an area that I am very passionate about. And off the back of that, I'm actually then going to do one on capacity and consent as well, because again, that's something I'm very, very passionate about, particularly around capacity and consent in sort of adolescents, teenagers, because I do believe that, you know, that is a bit of a minefield, and the whole Gillick competence and the Fraser guidelines don't just apply strict. You know, they were designed for contraception, but they are applicable to many other areas of capacity and consent. So yes, we'll do a webinar on that. Managing specialist sports injuries. So actually, yes, things like what happens at horse racing or motocross. Absolutely, we can look at the operational aspects of managing the injuries in those particular environments. Not a problem. Legal side of mental health. Not an expert on that, Tom. So I may well do some research and see if I can develop my own understanding to a point where I'll be comfortable presenting on it. I don't want to present on anything that I've not got sufficient kind of grounding in myself, but I will have a look at it. Anatomy, that will be STC. If you look on our YouTube channel, you'll find on our playlists of STC videos, there are 2 anatomy and physiology webinars by STC Training Solutions. Collier, ECG, I can point you in a direction of a series of 8 webinars from STCC Training Solutions on YouTube. They cover everything from the very basics of lead placement and what an ECG is, all the way up to things like Wolff-Parkinson, White syndrome, arrest rhythms, Brugada syndrome, branch blocks, and so on. Psychoactive substances, yes, and other substances that we may well encounter in the event world. We can certainly do a section of those. Thomas, dealing with mass casualty in events, I'm going to refer you to our YouTube channel. There are about 3 webinars that will be appropriate to dealing with mass casualties in events. So please do watch the YouTube videos that are already out there. I think we may well rerun those, but probably not until a lot closer when the event sector is likely to start running. Management of Collier, not quite sure what management of. So yes, lots of suggestions. I'm gonna management of seizures. Yes, there are operational aspects to seizures. We can certainly look at those, not a problem. What I'm going to do is I'm going to stop waffling on right now. It's 2046. I'm going to leave the chat service open until 2050. If you want to throw any more suggestions in there, please happily do so. If you need to click on any of the links in the chat, please do as well. If you want to share your own contact details and network with people, you've got another 3.5 minutes to do that. Anything else, email us, webinars@promed999.co.uk, and I look forward to seeing you all in 2 weeks' time. Goodbye now.